Good? Okay. Can you hear me? Everything's okay?
Yes, we can hear you well.
Okay. How is it? How are you doing? How's Ukraine?
It's fine. The weather is pretty warm today.
Good,
So,
good. Everyone safe?
yes, of
Good,
course.
good. We have a lot to cover. Um, if I go too fast, just tell me and I'll slow down.
Okay.
Sometimes I speak too fast, but tell me. And then just let me know when to start.
Okay, I think we need a couple of minutes more to
Okay,
everyone join us.
okay.
Yes.
I'm just gonna grab some water.
I can see the scar on the finger right here.
Yeah, barely, yeah.
Yeah. A couple years ago, I was walking from work, holding my phone, just texting someone, and I heard what sounded like the baseball bat, baseball bat, and something. Folks this day have no idea what it was.
Wow, that's weird. So what happened here? My video went off.
Okay, Dr. Phillips, I think we can start.
We're good? All right, good morning, everybody.
Good morning, good day, because in
Good day,
Ukraine,
yes.
yes,
Good,
it's 3 p.m.
good afternoon, I should say.
Yes, yes, good afternoon.
Well, thank you for having me again. We have a lot to talk about, a lot to cover, but we're going to try. If I start talking too fast, tell me, I'll slow down. But I'd like to make sure we try and get through the real heart of this, the treatment of burn injuries. We left off last week talking about the zones of injury. And I asked everyone to think about if we put a hot bar or we touch the muffler to our leg, something hot, that the very hottest area of that wound would be immediately dead. We call that the zone of coagulation here. As that heat dissipates, as it moves through the tissue, the temperature drops, and then we start having potentially healthy and viable tissue. So the zone of coagulation, immediate death, 45 degrees Celsius and above. That for us is a primary injury. We can't do anything about that. We can't save that tissue. There's nothing that in all of our treatments we can do that directly treats the center part. However, as that heat moves through the tissues, we now have a zone of stasis, still alive. It's marginal, but it's still possibly we can save it. And then even farther out, we have the zone of hyperemia. When you look at a burn patient and you look closely, you'll see the zones. Maria made a very good point last week about how burn wounds evolve. What looks today might look very different tomorrow or a couple of days from now. This is why. This is something that we always have to assess and then we have to treat. So we can't treat the primary zone, the zone of coagulation. However, all of our treatments are focused on those other zones. So we have to be very dogmatic. We have to be very attentive to our treatments. In burn wounds, when you have a patient come to you, we define the process into 3 distinct phases: the resuscitative phase, the acute phase, and then the rehabilitative phase. Let's go through those a little bit. The resuscitative phase is from the time of injury through 48 to 96 hours. Everybody's a little bit different, but it usually lasts 2 to 4 days. That depends on your management. That's when you see us be very aggressive. If you're going to save the lives of a burn patient, this is the single most important time. Any delays are going to manifest in organ dysfunction, organ failure, and death. So we have to be very aggressive early on. That includes early surgery. In the old days, when I was a student, when I was a resident, we would not operate on patients for a week. We would resuscitate them. We would try to normalize all of their labs. And then eventually we would take them to the operating room. Many of them were very, very sick by that time. And we learned the hard way, this is not good treatment. We have to be more aggressive. A female surgeon in Prague actually taught us, the burn world, that early surgery is the standard of care. She proved that in children. Once we get past that resuscitative phase, now we're starting to normalize the physiology. We enter an acute phase, and that can last days, weeks, even months. It lasts until you are able to close the wound. You think of a burned arm. When somebody has an entire extremity burned, we break it into stages and phases. We excise that wound. We get coverage. And now, physiologically, hopefully, things start normalizing. Diuresis is a very significant part of this phase. You will see patients mobilize all that fluid that we had to give them early on. It's to be expected. Our goal in this phase is just to normalize the patient's physiology. Once you've closed the wound, now we start maturing that wound bed. We are in the rehabilitative phase, and that can last for years. I mentioned last week about the deformations and the contractures and all of the long-term issues we have with burn patients. It's all part of this rehabilitative phase. Aggressive reconstruction, aggressive physical therapy, exercise, good nutritional support, and they will eventually complete even that phase. So, where do we start? This is the heart, right? This is what we're all doctors, we're all clinicians. We love to take care of patients. This is it. They bring a burn patient to you from whatever mechanism, an explosion, a house fire, a car fire. Our first job is to stop the burning process. It seems very normal. It seems very taken for granted. But there's more to it, right? Think of the zones of injury. We want to remove that extra source of heat. So you will see us, and I'm sure you guys have your own guidelines, your own protocols. We strip our patients, we wash our patients. We want to remove any extra sources of heat. We want to stop that burning. Cover your patients up after that, keep them warm, try to minimize those other problems. But first and foremost, we stop the burning. Second, airway. Always the airway. I always teach my students, my residents, fellows, doctors, worry about the airway. We can deal with other issues, but once we lose this, we're in trouble. We put everybody on high flow oxygen. We start with 100%, everybody. That might be for an hour or two. That might be for 4, 6, 8 hours. But everybody gets put on 100% oxygen, whether we intubate them or not. As I said, we remove all the clothing, we keep the patient warm, and then we start IVs. Our choice of IVs is the antecubital fossa, 2 large bore IVs, just like any trauma patient. We say in our world that all burn patients are trauma patients first. We rule out trauma, head injury, bleeding, broken bones, and then we deal with the burns. If it's a chemical exposure, hopefully we will have known that, or as you're first assessing your patient, you will see this foreign substance. Wash it, wipe it off first. If it's dry powder, just protect yourself, gloves, wipe it all off, and then wash your patient. Clean water. We don't use detoxifying agents. We don't spray them with soaps or anything like that. We just use clean water. And then they're going to likely be in pain. We want to treat their pain, try to keep them as calm as we can, sedate them as you need to. Remember, though, in trauma patients, sometimes we use muscular injections, IM injections. In burn patients, we don't recommend that. It's very inconsistent on their absorption. So we put everything through their IVs. So IV access is crucial. Let's focus on the airway for a moment. When you look at your patient, divide them into 2 types. Do I have airway injury above the glottis? Or am I suspicious that it's below the glottis? In your mind, it can be very important. Above the glottis injuries will look very impressive. They'll have singed nasal hairs, facial hair if they have beards. Their eyebrows might even be burned off. They might have blistering around the face. If you open their mouth, you might even see black carbonaceous sputum, this charcoal-like sputum that they're coughing out or spitting out. If it's below the glottis, your patient might look very normal. There may be none of that. They've inhaled enough of that hot air, that hot smoke, and it's damaged below the glottis. When they first present to you in your ER, they're likely going to be awake, they're going to be talking, They're not going to be coughing and bringing up all this black stuff, but they have a very serious lower airway injury, and we have to be cognizant of that. If there's any suspicion at all, I would recommend intubating. Whoops. What's going on? Intubating your patient. This is a very typical upper airway burn. You can see the blistering in his nose and around his eyes. If you could see his eyebrow up here, it's already been burned off. You open his mouth, you see black, tarry type sputum. I would intubate this patient, no hesitation. Before I do anything else, start my IVs, give him the appropriate medications, and secure the airway. Okay? Soot around the nose, burned hairs, shortness of breath plus minus. Don't let that fool you. The patient may not be short of breath yet. And then wheezing, the other signs of airway distress. This is very, very flexible. This is some patients have very different manifestations. Not everyone is going to have all of these signs. So you and your clinical judgment, you just have to make the best decision you can. If they come in disoriented, obtunded, even comatose, remember, trauma first. We don't know most times what actually happened. Maybe it was a house fire and there was an explosion. Or maybe there was a mortar attack with an explosion and a blast injury. Then the patient secondarily caught on fire. So trauma first. Rule out head injury, rule out head bleeds and those types of things. But assume this may be carbon monoxide poisoning. Again, start with 100% oxygen. Okay? Anybody in the burn world who comes to your clinic or your ER, your office, and has a hoarse voice, is coughing, is going to get intubated. We can always extubate them, right? We have anesthesia experts. Most of us who do this work are comfortable with the airway. If you make the mistake and the patient does not have an airway injury, that's okay. We can pull the tube out tomorrow or the next day. But if we don't secure the airway, that's when patients die. These are the things, of course, you're looking for. Typical signs of respiratory distress. Be aggressive. Secure your airway. Young boy burned pretty soon after the injury. He was brought in. This is a picture showing you his injuries. He has very suspicious signs that he might have an airway injury. In our world, we try not to do nasotracheal intubations. We try. If we have to, we have to. It's okay. It's better than not having an airway. They secured his airway by putting a nasal tube in. That's fine. But I want to show you what happens over the next day or two. This is 24 hours later. We still have our airway, but look at the difference between this young man. Same boy, one day. So if we don't, look at the size of his neck. Imagine all that edema fluid. It's not just what we see here externally, it's internally. If you lose this tube, that airway, if I could ask Maria or someone at the end to comment about these, that airway is going to be swollen shut, and you will not be able to get a tube down through it. We will be doing a surgical airway, a trach. Airway injuries increase all of the risks. They increase pneumonias, they increase the length of stay, they increase our cost, and they significantly increase mortality. They are an independent predictor of mortality. which is why I'm always encouraging everyone to be very aggressive with the airway. Carbon monoxide, cyanide poisoning, those are the things that really physiologically lead to death. Carbon monoxide has a 200 to 250 times greater affinity than oxygen. It'll displace oxygen from hemoglobin, and you will not be able to replace it. You have to wash that out with high flow oxygen and then wait. It takes time. You're not going to be able to do this just in the emergency room. When we look back at most patients in the United States that have died from their burn injury at the scene, it is almost always related to asphyxiation, subsequent carbon monoxide poisoning. The way they present to your hospital can vary, and it varies based on how much of the exposure and how long of the exposure. So if it was short time, relatively controlled fire, not in an enclosed space, there was at least some source of fresh air, the patient might walk into your hospital looking fine. They might be breathing fine. But don't let that fool you, because until you check their blood count, their carbon monoxide level, you don't know how much of an injury they have. In the old days, we would have to draw a blood sample and send it to the lab. We don't have to do that now. We have pulse oximeters that measure carbon monoxide level. Just like you put a pulse ox to measure oxygen saturation, they make machines. I imagine you guys might even have these. And there's different versions, there's different models, but you hook the oximeter up to the patient's finger and you get a carbon monoxide level. Remember, the carbon monoxide level is what leads to symptoms and even eventually death. So someone that comes in, they're complaining of trouble seeing, or they have some blurriness. A lot of times they'll be tearing in the eyes. If you check their carbon monoxide level, they're usually down here, 5–10%. As we increase that level, we worsen the symptoms. Headaches, they appear red. Remember, that carbon monoxide has saturated hemoglobin. If you check a regular pulse ox, it's 100% on your monitor. The hemoglobin is fully saturated, but it's saturated with carbon monoxide, not oxygen. So don't trust your pulse ox, your normal monitor. As you increase carbon monoxide levels, the symptoms get worse. Nausea, you'll sometimes even see them kind of start getting very unstable. If they try to get up and walk, they'll become they look like they're drunk. They'll just wobble and they're staggering. As you worsen the numbers even more, they get higher in carbon monoxide levels, the symptoms get very severe, leading eventually to death. The patients that die acutely are those that have greater than 45–50% carbon monoxide levels. How do we treat it? I've said several times now, high flow oxygen. We believe, and the literature supports us, that if we have suspicion of a carbon monoxide poisoning, we put everybody on a 4-hour washout. Doesn't matter, leave them on 100% oxygen for at least 4 hours, and if you do physiologic studies, in 4 hours on 100% oxygen, we will have displaced almost all of that carbon monoxide. So now we're oxygenating our patients. Molecular oxygen has bound to hemoglobin, and now we're back to normal physiology. There are many centers who treat these patients with hyperbaric oxygen. They put them in a chamber under very high pressure, 2 to 2.5 times atmospheric pressure, to try to speed this up even more. It's very good. The literature supports it. However, you must have a very stable patient, right? You can't put someone in a chamber, shut the doors, put them on high atmospheric pressure, and then their pressure drops from bleeding or from a lack of fluid or from something else. So if you have or you're at a center that offers hyperbaric oxygen, terrific, use it. Just make sure that your patients are stable. Fluid resuscitation, the heart of what we do. This is everything. If you remember just a few things from today, airway and fluid management. Patient comes into you. It was a relatively short time from the injury to our hospital. We don't need to spend a lot of time in the field trying to resuscitate patients. We would rather have them be brought to us very quickly and then let the doctors, your teams, your nurses do all the things they know how to do. Because the more time we spend in the field, the chances of under resuscitation go up. So if you're at a relatively close proximity to a hospital, get the patient to a hospital. If you can start an IV, start the IV, start fluids, terrific. But the priority needs to be get the patient away from the scene to the hospital. While you're in the ambulance, if you're part of a field crew, try to stop the burning process. Get all those clothes off. Pat your patient down, right? Even a wet washcloth will help. Keep the patient warm, get them to the hospital. Every book you read, every journal, every article you read in burn patients will talk about the Parkland formula. This used to be the mantra. This used to be the gold standard. Parkland formula. We don't use it anymore, but we might have to know about it. Parkland formula, very conventional teaching, still many times the answer for the exams, is 4 milliliters per kilogram per percent body surface area burned. We have to know that number. 4 milliliters per kilogram per percent burned. Remember, we talked last week, we do not count first-degree burns, right? Epidermal burns, superficial burns, they are not part of our calculation when it comes to body surface area burns in terms of fluid resuscitation. Second-degree, third-degree burns, that's when we get this number for our formula. We take that total amount, let's say, for example, 20 liters is the answer if our calculation is right, and we divide it in half. We give the first half 10 liters in the first 8 hours from the time of injury, not from when we see them in the hospital, but from the time of injury, okay? 10 liters of fluid, patient was burned 2 hours before they got to us. We have to take that into account. That 2 hours, we count up, okay? Some patients who are acting like they're under resuscitated, that's the reason. We've forgotten about, wait a minute, we didn't count that 2 or 3 hours that the patient was out in the field trying to get to us. So we take total amount, 20 liters, we cut it in half. The first 8 hours from time of injury, that's our fluid rate. Pretty simple. The second half, the remaining 10 liters, we then give over the next 16 hours. Okay? That is a rough ballpark. That'll get our patient within reason of being resuscitated. Our real goal is to monitor the urine output. We want, for an adult, 30 to 50 cc's per hour. If it's too low, it might be because we're not giving enough fluid. If it's too high, we're giving too much fluid, we need to back down. So the formula itself is a starting point. It is not written in stone, okay? Very important. You're all clinicians. We all have judgment. We have to monitor that patient every hour. And if we're not happy with our urine output, then it's up to us to adjust that, okay? Blood pressure, pulse, the other things that we usually monitor for resuscitation, especially in trauma patients, they may not help us in the burn world. If you have a cuff sitting on your patient's arm and you're trying to monitor blood pressure, we're pouring 20 liters of fluid into this patient. That patient swells up, just like that little boy in the picture. That blood pressure cuff may not be accurate. So oftentimes you'll see us put in A-lines and try to be a little bit more accurate with our numbers. The pulse, the same thing. Our goal is to normalize the patient. A little too high, it might not be because of fluids. That patient may be in pain. That patient may be very anxious, right? That patient may be scared to death, very understandably. So it's a little bit different than just a typical trauma patient. These are always things to look at, but don't necessarily trust them. Trust your urine output. Adults and children, they will tell you, hopefully they'll have normal renal function, what your treatment is like. Okay? If you're in the field, you're part of a trauma team that is at a small field care center, and you're trying to triage patients and get them to a hospital. We talked last week about how to measure, how to gauge burn injury. It's depth of burn and the extent of burn, the total size of the body involved. You can ballpark that very quickly in the field. We talked last week how to do that. If you have roughly a 20% burn patient, 15 to 25, in your head, start at 500 cc's an hour. You will be close to what the total fluid they need. If you have 25 to 50% injury, start at 750. If it's a very large burn, more than 50% of the body, start at 1 liter an hour, and then get the patient to the hospital, okay? Very rough, very approximate numbers, but for the most part, they will be close to what you need. In the United States, most burn centers, we use lactated ringers. We use LR. There are times when you'll see us use normal saline if the patient has a bad head injury. But most of the time, we try to use some version of lactated ringers. We want our fluid to be close to plasma, as close as we can get. If you end up having to use normal saline, it has a significant amount of sodium and chloride. Just expect the complication. 2 or 3 days from now, your patient will have a hyperchloremic metabolic alkalosis. They will be alkalotic. It's not from the burn, it's from the fluid that we gave them, all of this extra chloride. Okay? Just something to keep in mind as you're following these patients in the next 2 or 3 days. Burn injury causes everything bad. There is nothing good that comes from a burn injury. Decreases our cardiac output, increases our heart rate, if we can trust it, decreases perfusion. The decreased perfusion is what leads to organ failure, which leads to death. This is what we are trying to treat. This is what we are trying to prevent. Where does all that fluid come from? We see that boy in the picture where he swelled up, where he became very edematous. Burn injury systemically causes the spaces in our capillaries to dilate. If you look up the books, they will use the term interstices. The spacing in the endothelial wall, the wall of the capillary, the spaces between the cells get bigger. And all that fluid that was normally trapped in the capillary seeps out. It leaks out into the interstitium. That's what causes all the swelling, all that edema. We have to stay on top of this 6 hours, 12 hours, 24 hours, keeping the infusions going. We have to keep fluid in this capillary, even though we know it's going to leak out into the tissue. We don't have a choice. If you try to downsize or decrease your resuscitation during that resuscitative phase, you will cause organ injury. The real challenges in burns are these groups: elderly, usually above the age of 60, 60, pediatric patients, especially in the very young, less than 2, have the highest actual mortality, electrical burns, and then those with comorbid conditions. Elderly patients with CHF, COPD, they do not do well with burns. You remember last week we had the graph of all the different survival rates. The very young and the older patients do not do well. Even if you're the best doctor in Ukraine, you can only treat the patient so much. Okay, we talked about titrating our urine output. In children, we use 1 cc per kilo per hour. In adults, we use 0.5. If you're in this ballpark, 1 cc per kilo, you'll be doing great. You'll be doing just fine. Patient will do well. Expect, as we move from the resuscitative phase into the acute phase, significant diuresis. That diuresis is going to accompany the loss of potassium. So we have to monitor electrolytes. In our ICUs, we have to be very aggressive. And some of our patients will check them every 6 to 12 hours when we're in that acute phase, just to make sure we're not falling behind. I mentioned Parkland formula. There are literally 30 different burn formulas in the literature. 30. That tells us there's not a perfect formula. These are just some of the ones you'll see commonly used. You will not see Parkland used, at least in our country. It's too much fluid. It causes a lot of complications. Most of us nowadays use what's called a modified Brook. That is 2 cc's, not 4, 2 cc's per kilo per percent body surface area burned. Okay? One of the keys to try to remember today: airway, fluids are important. Try to use isotonic fluid, LR, something like that. And then 2 cc's per kilo per percent. Follow the urine output and adjust as necessary. Okay? Modified Brook, 2 cc's, not Parkland. We can always give a little bit more fluid. We can't take that fluid away once it's given. In children, remember, especially very young children, they do not have a lot of glucose stores. So we have to give them a source of glucose. We would start, in addition to our resuscitation formula, which is LR, we would start a second fluid with a little bit of sugar, a little bit of dextrose. So D5 LR. Only in our children, though. We don't usually do that in adults. Very young children, you'll see us also use what's called a D5 half normal. Again, another way to try to minimize some of the alkalosis and other issues we have physiologically. And we calculate their fluid management based on a 4-2-1 method. If you look at the 4-2-1 method, it's 4 cc's for the first 10 kilograms, 2 cc's for kilograms 10 through 20, and then 1 cc for all kilograms after 20. So when you start working with kids, I imagine many of you do, you become very comfortable with how much fluid should I give my burn child. Whether we're working with adults or children, we try to objectify our burn fluid management. We don't want to give patients too much fluid. So we will put in central lines. We will follow CVPs. In the old days, we would put in Swan Ganz catheters. We don't use Swans very much. We will instead do bedside echo. We'll follow the echo of the heart and see. If your patient is bleeding, if your patient has an accompanying traumatic injury, which in areas of conflict, war zones, is very common. You'll have patients with multiple injuries. Then we have to worry about not just the burn wound and the IV fluid, but also the blood loss, right? We always encourage people from a trauma standpoint to try to reconstitute whole blood. If we are having a hemorrhaging patient, we transfuse that patient. We don't want to give them just blood. We want to give them plasma and platelets. In an acute hemorrhage, significant hemorrhage, we're going to try our best to do a 1-to-1-to-1 resuscitation. That is in addition to all of the fluid you have to give for your burn patient. It can be very challenging. It can also lead us to this circle. In the United States, we call it the bloody vicious circle. Let me walk us through this real quick. We have a burn patient. We are giving them a ton of fluid, 20, 30, 40 liters of fluid. We hemodilute that patient. Our fluid, even though we try to keep it warm, might cause hypothermia. Those two things are then going to lead to coagulopathy. As you well know, patients do not like to be diluted or cold. Coagulopathy leads to bleeding. Bleeding makes us more, we have to do more for resuscitation. We have to give them more fluid. Sometimes we have to give them blood. And now we keep going around and around the circle. We call it a death spiral eventually. No matter what we do, we can't keep up. And the way to stop that is to start operating on your patient. We try to minimize the amount of fluids. We try to correct the coagulopathy. This is the 4-2-1 method I mentioned earlier. Pretty standard. I'm sure all of you are comfortable with it. It only really works in children. We don't use it too often in adults. I mentioned a little bit earlier that too much fluid is bad. We know that over-resuscitation leads to death. It leads to abdominal compartment syndrome. It leads to problems with oxygenating and ventilating our patients. It leads to worsening wound healing. Too much fluid causes major problems, big problems. That is why at some point we have to stop just giving fluid. We have to be good doctors, good nurses, good providers, and think about the other options we have. Inotropic support. Many times you will see us start patients on low-dose Levophed or epinephrine or dobutamine, trying to minimize how much fluid we're having to give. Adequate endpoints, try to normalize the patient's hemodynamics. I mentioned earlier, we can't necessarily trust the blood pressure or the pulse. Follow the urine output, follow the labs. We do not want the patient to be acidotic. So the chemical markers of perfusion, lactate, and those types of things, try to normalize as much as possible. Okay? That's our real goal. Remember, we can't treat the primary burn injury, that center zone. Everything we do, all of your work here, the next 2-3 days in the ICU, everything is focused on trying to save as much as that zone of stasis, zone of hyperemia tissue that's at risk. Normalize all of your blood work. If you have a high base deficit, if you have a high bicarbonate, those are the markers. Those are the physiologic reasons to act and be aggressive. Feeding is incredibly important in a burn patient. In a trauma patient, you'll see us wait 2 or 3 days. In the burn patient, assuming there's no GI trauma, we want that nutrition started as early as possible. Many protocols in the United States tell us start it within 12 hours. Get your feeding going. Put a Dobhoff or a feeding tube in. Start trickling in some calories, some nutrition. And then, if the patient's tolerating it, increase it to goal. Be very aggressive with nutrition. Having said that, we don't want high sugars. Maintain normal glycemia. Hyperglycemia in the burn patient worsens outcome. It increases infection. Nutrition, as I said, is incredibly important. It helps in many places, especially in pediatric units. We consider it part of our resuscitation. It is that critical. So be aggressive with that. Enteral formulas, I'm sure you guys have your own choices. And in our country, there's different formulas. There's different hospitals have different pharmacy-approved formulations. A lot of it's based on cost. I think for the most part, they're all very similar. So whatever you're able to use, get it working, get it into your patient and get those calories. From a physiologic standpoint, the big difference between a trauma patient and a burn patient is this one word: hypermetabolic. Burn injury causes a hypermetabolic state. That state can last all the way from time of injury out to 2 to 3 years. That patient is hypermetabolic. Again, you can't trust your pulse, your blood pressure. It is part of the physiologic response to burns. They burn through protein. They will waste away their muscles. Even though you're giving them nutrition, even though you've operated on them, you've skin grafted them, you're starting physical therapy, it is this hypermetabolism that we are fighting for months and possibly years. So very high protein diets, significant calories. You and I eat about 2,000 calories a day, somewhere in there. A burn patient, an adult large surface area burn patient, very commonly will get 4,000, 5,000 calories a day. Think of that. It is an incredible amount of hypermetabolism. There are different formulas in our world. There's always a formula. Pick one and use it. You'll be in the ballpark. We're very lucky. We have nutritionists. They help us. When I teach my students and residents, we teach them the Curare formula. We estimate calories based on kilograms, 25 times weight, and then we add another 40 plus your percent body surface area burned. Again, there are many formulas. Whatever your hospital has, use it, start it early, it's going to help. If you don't have one and you're seeing burn patients, this would be a good issue to address. Serum markers, there's all kinds of them. The big four in our country are albumin, transferrin, prealbumin, and retinol binding protein. Unfortunately, they've never been shown to independently help us predict outcome. We still use them, but we don't have good literature telling us that they're accurate. Many of the big centers will put what's called a metabolic cart study on patients, where they'll measure their metabolic rate by CO2, but it's very expensive. Weight loss is one of our key markers. I told you that burn patients, even though you're doing everything correct, you've been the best doctor in all the world, your burn patients are hypermetabolic. They're burning through calories. If we see weight loss of more than 1% per day, that triggers more aggressive treatment. First, make sure we're not missing infection. Second, let's address our nutritional support. So this is a big red flag. You should measure this every so often in your burn unit. We do it on a twice weekly matter in the centers I've worked at. Mondays and Thursdays, everybody gets a formal weight. And let's hope it's accurate. Because if we start seeing a bad trend, then we know we're missing something. Burn wounds. What do we do with it? Now we've done all this resuscitation, we're on track. What do we do with the wounds? First and foremost, we talked last week, if they're circumferential, their entire arm, leg, torso, first, we do eschorotomy. You'll see some images here. All we're trying to do is divide the burned skin envelope. We need to cut the tourniquet effect. That swollen tissue with scarred, thickened outer epidermal tissue, it won't relax. It will actually cause a tourniquet effect on your blood flow. So first and foremost, we cut the tourniquet. This can be done in the field. This can be done with a scalpel. I mentioned last week we do it nowadays, if we can, with cautery, with electrocautery. The reason is it bleeds, right? You will see us do this in the field. We'll do it in an ambulance. I've done it on the side of the road because the patient, by the time we got there, was out in the ditch for hours. So you can do this. It is just expect the blood loss. It is not a deep cut. We're not cutting into muscle when we do eschorotomies. All we have to do is cut down to the subcutaneous fat. Cut the skin envelope. Okay? It is not just arms and legs. You can have a circumferential burn around the torso. As we give more and more fluid, patients start swelling. Their chest can no longer expand. You will see them have more and more trouble breathing. Their pulse ox drops, their CO2 goes up, and now we have a thoracic compartment syndrome. We do the same as we would on an arm or leg. We cut the tourniquet, cut through that burned skin, and allow that chest wall to expand. Again, with a knife, cut the tourniquet. We can deal with the bleeding. I hope it's not too bloody. If it is, you have to sew it. You have to try to stop it. Nowadays with cautery, just take your time and it becomes very, very dry. I have done multiple full body eschorotomies. Torso, chest, neck, all extremities. Patients can survive, but you have to be aggressive. Surgery for wounds. I mentioned earlier today that when I came up through the schools, we didn't operate for a week. That is wrong. We operate now starting as early as day 2, 48 hours. Day 3, day 4, we keep operating every day until we have removed the burn wound. We've learned that that is the way to stop the acute phase. We do it on extremities, adults and children. We'll do faces, we'll do necks, wherever the patient is burned. Our goal is early excision, get the burn skin off, remove it. and then coverage. We can coverage with cadaver skin, if that's available, or ideally, the patient's own skin. Just take a skin graft, we mesh it to expand our surface area, and then sew it on or staple it on. Once we have coverage of the burn wound, then we start physiologically normalizing the patient. Early excision, 24 to 72. Many centers do 48 to 72. It's all up to you. It's up to your doctors and what they're comfortable with. If you're going to operate on patients, certainly within 24 hours, you must have a very good anesthesia team. We work together. It's not just surgeons saying, do this, do this, do this. Anesthesia teams are incredibly important. They are the ones that are going to monitor our resuscitation while we're in there doing the surgery, right? So we have to work together, especially if we're going to be this aggressive. I have operated on many patients within 24 hours. It does speed up the whole process. We just have to be very careful. We don't want to fall behind either in our resuscitation or our blood loss in the operating room. So be aggressive, early excise. If it's a large surface area, you're talking 30, 40, 50% of the patient is burned. We don't excise all that at once. We do staged excisions. We try to excise 10 or 15% at a time. That is why we go back every day. Take off small pieces. Limit the blood loss. Limit the hypothermia. Limit the time under anesthesia. Get them back to your ICU, warm them up, resuscitate them, take them back the next day. So you will see this. This has become very standard in our country. Take them back every day, every 24 hours, until the burn wound is excised and we have coverage. Okay, summary. 2 weeks. Acute care starts at time 0. It starts at the time of burn injury. Field care for us is incredibly important. Stop the burning process, start the IVs, start some type of fluid resuscitation. When they get to you, map your patient. Decide what level of burn and how much of the body surface area is involved. For our formulas, remember, we do not count epidermal burns, sunburns, 1st degree. We only count 2nd and 3rd degree burns. The formulas we use now for our fluid resuscitation, modified Brook, 2 cc's per kilo per percent. Airway is always the priority. Any question, intubate them. If we're wrong, patient doesn't have an airway injury, we will extubate them tomorrow, maybe the next day. But if we lose the airway, no chance. Care continues minute by minute, hour by hour, until we have the patient through the resuscitation phase, all the wounds excised, all the areas covered, and we're now hopefully well into the acute phase. We optimize nutrition, and we try our best to minimize infection. It should be a very smooth process. The thing that hurts us in the burn world is roller coasters. We don't want patients over-resuscitated or under-resuscitated. We want to try to normalize things the best we can. That's treatment. I know it was a lot. I appreciate everybody sticking with me, but I'll try to answer whatever questions you might have.
Dr. Phillips, thank you for this brilliant lecture. Colleagues, if you have any questions, you can ask them.
Thank you.
Okay, there is one question from Maria in our chat. What is the recommended rate and dose of albumin infusion?
Good question. In our country, we do not use colloid, any colloid, for at least the first 8 to 12 hours from the burn injury. We only use crystalloid. We only use lactated ringers or something like that. It's because if we give albumin or colloid too early, it all just seeps out into the tissue. Remember that picture where all the capillaries, everything's just flowing out of the capillary? The albumin will flow out. It won't stay in the capillary. After 8 to 12 hours from the time of burn injury, then you'll see many of us use albumin or even plasma as a colloid. We're trying to increase colloid pressure in the capillary. Many centers will do 1 cc per kilo per hour as a constant drip, trying to increase that colloid pressure while minimizing some of the IV crystalloid. Does that make sense? So many centers in our country for albumin, after 8 to 12 hours, we will use 1 cc per kilo per hour. We can go up or we can come down, but that's a pretty good starting point. Terrific question.
Okay, and I have some questions too. What do you think about using synthetic colloids like gelatins instead of albumin or plasma?
Yeah, we've not had much luck in our country, and we've tried lots of things. People are still trying the synthetic colloids and synthetic type substances. We used to use Hespan and those types of colloidal infusions. We've never been able to show that they are worth the cost. For us, it's very expensive. We hope that our labs or someone in the world will develop a perfect solution, something that stays in the capillary and doesn't leak everywhere. But so far, we've not been able to find that.
Okay, thank you. And the other question, what materials do you use to cover wounds besides skin grafts?
Yes. If we're able to have a skin graft on the wound, then for us, we will put a non-adherent dressing covered with bacitracin or antibiotic ointment, and then fluff dressing, a Curlex and padded dressings to take care of our grafts. We leave those dressings on for 4 days, and then we take everything off and look at our skin graft. If we don't have skin graft on, whether it's cadaver or autograft, then many of us will use a silver impregnated dressing. I don't know what's available in Ukraine. I'm sure you have lots of options, but silver itself is antibacterial. It's bacteriostatic. So it will help limit any underlying infection. So in our world, we will use various types of silver impregnated dressings. I don't know if there's a perfect one. They all have strengths and weaknesses, pros and cons, but they do help us.
Okay, thank you. And I have one more question about antimicrobial therapy. When do you start it?
Yeah, very good question. In our world, there's zero role for prophylactic antibiotics. None. Even with inhalation injury, we do not give antibiotics to burn patients prophylactically. We will give them a tetanus shot, and then we look for signs of infection. We have learned the hard way that if we just give antibiotics prophylactically, it worsens resistance. So when the patient does develop a pneumonia, it won't be something simple to treat. It will be a very resistant organism. So very good question. The role of antibiotics in burns only for suspicious signs of infection, fever, high white count, clinical signs of infection, your graft has purulent drainage, those types of things, or documented infection. You have cultures from your lungs showing a pneumonia. Then we'll treat it. But no role, at least in our country, for prophylactic antibiotics.
Okay, thank you. And we get a couple more questions in
Sure.
our chat. The first one is from Vladimir. What stage of treatment is the best for measuring the percentage of burned tissue?
As soon as they come to you, as soon as you see the patient in your ER for your first assessment, you should document the depth of injury, first, second, third degree, and the extent of injury, how much of the body's surface area is burned. That's our starting point. And then, at least what we do, every time we take the patient to the operating room, we redraw their map. We look at them again. We take all the dressings off. They're there under anesthesia in a nice warm operating room. We turn our heat up in the operating room and we remap that patient because burn wounds evolve. Just because it looks okay today, it might look very different tomorrow or next day. So every time we're going to the operating, we're reassessing that burn wound.
Okay, thank you. And one more question from Chris. Is it because the low hydrostatic pressure in capillaries that we don't use albumin in first 8-12 hours?
Yes, it's because of the gap in the endothelial cells. The gaps in the capillary wall are too big. So even albumin, which is a very large molecule, the gaps are so big in that endothelial wall, albumin will move right through. It won't stay in the capillary. So we know that colloidal pressure is low as we're pouring more and more crystalloid fluid into our patient. We're going to lower colloidal pressure in the capillary. But if we give it too early, prior to that 8 to 12 hour window, it's not going to stay in the capillary. It all seeps out and it makes our edema much worse. Does that make sense?
Yeah. Thank you very much, Dr. Phillips. We have
course.
no more questions.
I do have just one last question. Sorry about that. Thank you. Maybe I skipped the answer, but I just wondering why we do have like about fluid. You said D5 lactate ringers we just using for a very little, very young patient. Why just for them?
Good question. In our young patients, less than the age of 6, we know that their glycogen stores, the storage of glucose in the liver, is very low. It's very transient. Most of us adults, we can survive 6 or 8 hours and still have a little bit of glycogen storage in our liver. In children, less than the age of 6, they burn through their glycogen store in an hour or 2. So if we don't give them a source of glucose or dextrose, they're burning protein. And that's the last thing we want. We don't want them to burn protein. We don't want them to burn muscle just to generate calories, energy. So very good question. Less than the age of 6, try to remember they need a source of glucose. We have to try to restore and maintain their glycogen.
Thank you.
Thank you, Professor.
You're welcome.
Although we focused today on the acute care and management, there was a case I saw about a patient who had 75% burns, and he had a face transplant, multiple after this in the years that preceded or the years that exceeded his treatment. Yes. So, but then it was interesting to me because he complained about, for him, he was drawing a direct correlation between this transplant and development of metabolic disorders, especially diabetes mellitus. So I was kind of curious, trying to understand how and why, if at all, there is any such correlations between such a condition, transplants, and him developing diabetes mellitus. post the face transplant?
Not that I'm aware of. I don't know of any literature that shows a correlation between those two. I do know that transiently, during that hypermetabolic response that burn patients go through, they can become insulin resistant. That they will manifest as a diabetes type picture. But at least the literature that I know of, that's transient. So I'm going to have to go look and see if there's any reports of long-term onset of diabetes following burn injury. That would surprise me.
That's great. Yeah, his name is Robert Chelsea. I think it was a BBC documentary, so that could help you with your research.
Okay, I'll look into it. I always like to learn something. We'll see. If you have time for one last thing, I will show you a slideshow. It's about 3 minutes. If you
That
want.
would be nice. Yes.
Let me see if it works.
Talk with you again. Something vision softly again. Left it scenes while I was sleeping. Treasure that was planted.
I'm sorry, but I still see slides on my screen.
Uh-oh. Are you seeing the presentation at all?
It just didn't close yet, but we could not see any videos yet.
Let's see. Is it closed now?
Yes.
Okay.
Yes.
Let me try again. I'm glad you stopped it, because can you see that?
Not yet.
Not yet. Let's see. How's that?
Almost there?
Okay. And then slideshow. Is that working? Black?
Now it's black. Yes.
Talk with you again. Something vision softly again. Left it scenes while I was sleeping. Treasure that was planted in my grave. Stay in me. Of silence. Restless dreams I walked alone. Streets of cobblestone. The halo of streetlight. I turn my collar to the cold. So stare. Touch the sun. The sun. and naked lies. And those talking without speaking, people hearing people songs. Still silent. I'm silent. I was like a cancer. I'm silent.
I just wanted to share that with you. What you're doing is incredibly important. I know that your country is under a massive amount of stress and pressure. We all are thinking of you. We all hope for the very best. Our prayers are with you. Thank you for
Thank you,
letting me
Doctor.
talk and present.
Thank you, Dr. Phillips, for this amazing lecture. We really appreciate it, and thank you for additional materials. It was interesting for us. Thank you.
You're welcome. Take care. Be safe.
Thanks.
Okay.
Thank
Bye-bye.
you.
Thank you for the wonderful lecture.
You're
Thank you
welcome.
for your time.
Okay. Take care, guys. Be safe.
Thank you very much.